So what I want to do today is talk a little bit about community engagement and ways that we use that to improve health. My primary conflicts of interest are I believe in a society grounded in equity and justice, and I'm not an expert in anything, but I'm happy to share whatever I think I might be able to share with you today. So as you heard, it is Black History Month or National Black History Month. This is from the White House. And the origin of it really was proposed by Black educators at Kent State University in 1969, but it really comes from historian Carter G. Woodson, who was the second Black person to get a doctorate degree from Harvard. And he proposed National Negro Week, and it was the second week of February because that was the birthday of both Abraham Lincoln and Frederick Douglass. And what he said is, it's not so much Negro History Week as it is History Week. We should emphasize not Negro history, but the Negro in history. What we need is not a history of selected races or nations, but the history of the world void of national bias, race hatred, and religious prejudice. Okay? And so it's with that spirit of Carter G. Woodson that, when I think about National History Month or Black History Month, Black History Month, that I sort of take that as sort of my mantra. So when I look at the intersection between Black history and community engagement, Dr. James McCune was the first Black American physician to obtain a medical degree, and he got it from Glasgow in Scotland. And he was a leading voice in the mid-1800s to argue that the health of a person was not a consequence of their innate constitution, but of the community in which they resided, particularly in a race-structured society. And so now you're thinking about what's going on in the community and the importance of community for health. And that was followed up in the late 1800s by research by W.B. Du Bois, who, and on the slide, the chart on your left, you'll see in hatch bars, mortality rate in the white population, the black bars, mortality rate in the Black population in Philadelphia. And so he did an anthropologic assessment of select communities in Philadelphia and concluded that the racial differences were explained by economic, sanitation, and educational differences. And so in a sense, they were two of the early pioneers who highlighted that structural inequities and maldistribution of the social determinants of health as it relates to communities, rather than race as an innate construct per se, is the cause of health disparities. The importance today, if we look at 100 years later, if we look at health inequities and we think about health inequities, or at least in this analysis, health inequities was modeled as the difference in health that a group has now versus what was projected for healthy people 2030. It leads to a cost of about $1 trillion a year, affecting all communities. So both in minority communities, over 400 billion, and the white population, 600 billion. So the opportunity to not only improve health outcomes, health of individuals and families, but to reduce cost is substantial. So people doing work in this space should recognize that and be proud of the work that they're doing in this space. So I was going to say a little bit about, there was a 75-year-old woman who led a community-based organization dedicated to improving health and was very active in community academic partnerships. And she was brought to a local ER by her daughter. She had she had progressive confusion, anxiety, change in mental status over one day. Her blood pressure was low. She was placed on vasopressors and in the intensive care unit. And she was told her mother's diagnosis was end-stage Alzheimer's disease, and that she should be placed on a DNR and transferred to hospice or nursing facility. Okay. And the daughter then said, well, we'll come back to that in 1 second. I want to highlight a lot of the great work that's going on here at Stanford in community engagement. This one program in particular, community partnership program, launched in 2022, collaborating across the Bay with a wide range of collaborations, and both pillars in clinical care, education, and research. And I think that's the type of work that we would hope to see occurring more and more with academic health centers and medical schools across the country with our different community partners. The Stanford Department of Medicine has 4 mission areas: research, patient care, education, and community partnerships. Right? So that's great to see that community partnerships is highlighted. So I want to do my objectives today as it relates to community partnerships is talk a little about the history of addressing social determinants of health, how and why we leverage community partners, the science of community partnered research, and then fostering and strategies to foster a culture of respect and recognize community partner efforts. So first, talk a little about the history of serving rural and underserved communities, particularly focusing on the social determinants of health. And like us in LA, you here at Stanford are doing a lot of work with federally qualified health centers. But they just didn't appear like out of nowhere. It actually was the brainchild of Dr. Jack Geiger. And Dr. Geiger in the 1950s as a medical student spent 5 months in rural South Africa working on a project that was based with community workers doing annual household surveys. And he took that experience, and when he was engaged in the civil rights movement in the South, he realized, particularly in the Mississippi Delta, that the health outcomes were very poor. And so he started the Delta Health Center in 1965, along with Dr. Count Gibson, shown here. And Count Gibson, the partnership, Count Gibson was at Tufts. Politically, they got the money to do the Delta Health Center, but also start a similar center in Boston, right? So it's politics. And then John Hatch, who's shown here, kneeling next to him where the construction's going on, was from Mississippi, and he was working with Dr. Hatch up in Boston. And so they together put this, but it was really Dr. Geiger who sort of led this. And he came under a lot of scrutiny when he was working there. First, he wasn't really welcomed in the South because no one wanted to say that there's bad health outcomes going on. And he was writing prescriptions for food that was coming out of the pharmacy budget. And so they threatened to take away his license for malpractice for doing that, right? And he said, of course, the last time I looked, the specific therapy for malnutrition was food. And nobody bothered him after that, right? So those two centers became the nidus of what is now FQHCs across the country that care for over 30 million people. My personal journey into community engagement per se was really inspired by these two gentlemen, Dr. Alfred Haynes, who had worked at Hopkins, University of Vermont, spent time in Indian Health Center and in India. And he really was focusing on working with families. And he published an article in JAMA in 1960 about this. And then he left Hopkins to come and be help build a new medical school in, or at least the academic center, and what became a medical school in Los Angeles, which was the Charles R. Drew Medical School. He subsequently helped to recruit Dr. David Satcher there, and Dr. David Satcher went on to have quite a career to both lead the CDC and become the Surgeon General. But at the CDC, the Maternal Fetal Health Division worked with him, and he supported their starting a community-based participatory research program on fetal maternal health. Okay. So now we'll sort of shift gears a little bit and talk about these community partnered strategies. So the work that I do is in memory of Dr. Loretta Jones. Loretta had a master's degree in social work and was a leader in the South Central Los Angeles community, later got a doctorate in theology. And she was the recipient, her organization led by her and the UCLA School of Public Health and Charles Drew University was a recipient of one of these first community-based participatory research, or CBPR grants, in 1992. And she didn't get along with the person who was at Charles Drew. She didn't like him. She talked to the CDC, they threw him off, and they made me the PI from Charles Drew. And as a nephrologist, that made perfect sense, right, for fetal maternal health. But she and I had worked together for a few years on some other things. And so it was great for me to just be involved and to support, right, in whatever way I could. And so what is CBPR? It's this Kellogg Foundation definition, a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. I think that's like really captures it. Loretta said we should call it community-based participatory research rather than community-partnered participatory research to emphasize the partnering, right? And so Loretta always had great ideas, and so we would go with what Loretta says. So that's how that's sort of what we would use for much of our work in Los Angeles. It's sort of the same, but we were seeing a lot of projects that were based in the community, but were not partnered. And so people were using that term inappropriately. The term itself is great, but it was being used inappropriately. And so we like to use the partnered label to help emphasize it. And why would these approaches be important? One, who knows best what's going on in the community other than people in the community, right? We have databases and stuff like that. But also new approaches to achieve new results. And then how do we get the best evidence to the doorsteps of our patients? And really working with community leaders, community advocates, I think we're better positioned to make that happen. Now, there are different levels of community engagement. And I've just sort of highlighted some here from where the degree of partnership can vary, right? And it can go to where there's more dominated by the research or academic arm to fully partnered. And ultimately, my goal was always to say we will have achieved where we're trying to go when the community is coming, knocking on the door at the academic institution, saying, we have this project, we have this problem, we have some ideas of a project, we want to meet, we want you to help us address this. It's important to understand the difference between engagement and involvement. And I think everybody knows the difference when you're in a relationship, if you're involved or you're engaged, right? So think of the same thing with community, right? There's a difference between engaged and involved. So involvement is more like we consider a prearranged marriage. It's structured, pre-planned, et cetera, and engagement, you know, it's a collaboration. You're working together. You truly respect and value what the other partner brings. And I think that's an important strategy or approach to think about when you're getting involved in doing quote unquote community engagement. Now, there are a lot of barriers to it, right? There's a lot of times undervaluing community expertise. There's difference in language styles. Depending on the communities you're working with, it can be verbal language, it could be nonverbal language that's happening. There's a sense that academia is always right. The resources tend to go more to the university partner. Not really understanding the demands of time and the value of time for the community partners. When I go out to work with someone, I'm still being paid, right? I'm in meetings. My community partners, they may or may not, depending on what they're doing. And so we have to be cognizant of that. And then we all have different values and priorities as seen in the little cartoon in the top, right? And that's okay, right? That happens in all relationships. We just need to understand them and be transparent about them. And then limited training and opportunities to build partnerships. And so we see more and more now through clinical and translational science institutes and other research programs, a lot of training around strategies to help both academic partners and the community partners have a better understanding of the needs and priorities of their partners, because that's really important. And then there's a lot of expertise community brings that is often under-recognized, right? And so they have experience hands-on with the social determinants of health, particularly in their community, because how it's expressed will vary from community to community. The communication style, there's opportunities for faith-based approaches, neighborhood organizing, action to advance health justice, social justice. They're doing a lot of that. And so if you get with the right partner, us as institutions can be more centered in trying to bring what we have to offer, understand what communities are looking for, and hopefully together make something even better. So one thing we hear a lot with different communities are hard to reach. Communities are not hard to reach. Communities that we call hard to reach are hardly reached, right? And because they're hardly reached, they feel marginalized, isolated, and naturally, they're somewhat resistant to us coming in for whatever reason. If it's to do research, if it's related to a natural disaster, a pandemic, et cetera, it's very difficult, not because they are hard to reach, but because we've hardly ever reached them. And so as a society, we need to be thinking about that. We need to think about, again, the expertise they bring. Loretta would always talk about PhDs of the sidewalk that you want to work with, right? For bonus points, what's a WMD? So what matters degree, right? So that's another, Cheryl Grills at LMU talks about that. And so we really want to value the expertise that community members bring, right? And demonstrate that we understand what's feasible in the context of a given setting. And then for a lot of this work, it's important to consider a memorandum of understanding. So we don't do it all the time, but we've done many of them. And that helps to outline what the rules of engagement are, because after that first meeting, one thing you can pretty much be like 95 to 100% certain is the next time everybody comes back together, they will have a different understanding of what happened in the first meeting and what was agreed upon. Happens in a lot of other things we do too. Maybe we need MOUs for more things that we engage in. Well, what about the science of advancing knowledge using sort of community engagement? So one, a lot of people are like, oh, faculty, they're getting involved in community engagement, but where's the science? Are they doing science? Well, there are a lot of scientific methods and approaches that are really important for doing strong work in what we would consider community engagement. So quantitative research is important to have a background and understand the landscape for the prevalence and incidence of disease in different communities. Qualitative research to understand more the nuances and the insights of what's going on in a particular community. Implementation science is critical, and we have a lot of advances, but they're not getting to the doorsteps of our patients. We've done randomized controlled trials with community partners. And so we can do a variety of different approaches. And then of course, working with community partners to advance health policy is really powerful, because a lot of times political officials are looking to hear not just what the academic people are saying, but what the community is saying. And it's important. And if we're there together, it's much more powerful than either one coming alone. And then what most people miss, particularly in academia, is understanding the downstream consequences, the biological consequences of the factors in community that are leading to adverse health. And that understanding those biological consequences can really be crucial to advancing science in ways that we might not otherwise think of. Right? So if you think about particularly marginalized communities, where there may be high rates of poverty, classism, early life adversity, individuals there have a lot of psychobiosocial stress, right? And if you have that stress, it can lead to abnormal neurocognitive processing, abnormal biologic processing. So what happens with the neurocognitive processing? There's what's called the global workspace in the brain, right? And if you're under stress, things get rerouted so that you can handle and deal with the stresses. And two areas in particular become impacted most significantly. And that is your ability to remember and your ability to implement tasks, right? Your ability to remember, your ability to implement tasks. Something that's very important, clearly very important for our patients. There's also abnormal biologic processing that can impact gene expression as it relates to inflammation, the immune system, epigenetic changes, central sympathetic nervous system, neurohormonal activity, and all of these factors can lead to preclinical disease and eventually disease. And so when we think about clinical trials, we're usually not looking at differences in drug response across different communities and identities because of any different gene polymorphisms per se. We're usually looking at differences that is occurring because of alterations in biologic processing across the communities. And when we see a patient comes in, and we have a patient who is in a setting where they're being exposed to adverse social determinants of health. They're trying to struggle and make it, and they're prone to get suboptimal clinical outcomes. They may have increased comorbidities, advanced disease progression. They're thinking about that they're not trusting the the health community is yet another system. There's anxiety in going to see the doctor. And so it's a stressful situation. But there's also two things that we want our patients to do. And we talked about the abnormal neurocognitive processing. We want them to remember what we told them, and we want them to implement them. And those are two of the most important aspects of their cognitive space that are impaired. And they're not impaired, and they are impaired because of what's happening around them and what's being done to them. So if we can, as a society, if we can attenuate many of these elements, then hopefully we can improve our patient outcomes. And that's what community engagement helps to do, right? And we're thinking about what balls our patients may be dropping. But again, it also leads to a shift in thinking, not what's inherently wrong with my patient, but understanding and recognizing what has happened or been done to my patient. And that is why they're struggling. And I think that makes a difference in the relationship we have with our patients, right? So I just want to go over a few things that we've been doing in Los Angeles through our work. We saw during the COVID pandemic, there was marked disparities in hospitalizations, deaths in low income and mostly minority communities. And it was really related to structural inequities in society, risk of exposure, disease burden, access to quality care. And so that led to a variety of approaches. And one was through the NIH, what's called the Community Engagement Alliance, or SEAL. It was a statewide NIH project. Stanford was part of that project, along with other institutions. And our focus was working on the zip codes with the lowest income, right? Because we thought that's where we'd have the biggest impact. So we had all of the UC schools, academic health centers, many others, Merced, Riverside, Scripps, Stanford, San Diego State, Charles Drew University, all participated in this. And the strategy was to use bidirectional knowledge exchange, co-developing culturally tailored community relevant strategies. So the work was really led by community-based organizations that each academic center helped to sort of bring to the table and coordinate, but they actually did the work, right? Because they're best positioned to do the work, right? And so again, across a variety of academic centers, working with community-based organizations, all of these sort of principles of community partnered research, to planning, making sure everybody's included, transparency, trust. And what we saw was 11 universities coming together with more than 75 community-based organizations, over 550 town halls, over nearly 550 community health workers were trained, over 425 news features. We conducted over 150 focus groups over that period of time. It allowed us to get another grant through the state called Get Out the Vaccine, where we did canvassing. We canvassed nearly 6.5 million doors and had another 5 million contacts with phone calls, texts, and conversations via churches, health fairs, things of that nature. And, the impact, we had, the usual that they want to see: publications, more grants, et cetera, but we had many we developed new partnerships, and we think we had an improvement on health outcomes in these communities that are traditionally hard to reach. Right? What I'd hoped would happen after, one thing we recognized was in doing that work, the first thing people said was, well, what about these other services we need, sort of wraparound services, right? Yeah, COVID's great. Like, what about my housing? What about food? Things of that nature. So we've been trying to work with the state to continue to do some work in a way that allows us to continue to reach these communities who have been hardly reached, so that they'll be positioned and connected in a different way the next, on an ongoing basis, so that they feel more connected to society. Some things we're doing now: community health, AI education, particularly around AI and health. So that's really important. We have worked with Los Angeles County Department of Health Services to train community health workers to become community health technology navigators, to work with patient portals, things of that nature. And now we're trying to leverage some of these partnerships for the wildfire response. I'd say one of the things we were most proud of with the COVID work was, of the dollars we got, approximately 85% of those dollars went directly to our community partners. Right? And our goal is always to try to get, close to 50%. But that was one thing I thought was really great. So what about strategies to foster a culture of respect and to recognize community partner efforts? So the World Health Organization says, if we're going to improve health, we need to improve the conditions of daily life. We need to address the inequitable distribution of power, money, and resources. I won't tackle that one. That's beyond my pay grade. But develop a workforce trained in and raise public health awareness about the social determinants of health. So that's something I think that we can more immediately do. Doesn't mean we let the others go. There's a space we can have, but we can more directly affect that. So Loretta said to me, Keith, I was at Charles Drew University at the time, why don't we have a community faculty? We have people with community expertise. Why don't we have a community faculty? And I was like, many institutions in the business school, in arts, in music, they have adjunct faculty who do not have advanced degrees, but they have amazing expertise and knowledge, right? Bill Gates didn't finish college, and he might be interested in being adjunct faculty, and some school could say, well, our policy is you have to have be a graduate to be in our business school. So no, we don't want you. I don't think anybody said that to him, but that could be a position, right? So we worked with individuals who were, we had been working with a lot of people on a variety of different grants over a few years. And so many members who were working with different community-based organizations had knowledge around different social determinants of health in the community and had been working with academia. we went through a process to create what would be considered adjunct faculty, but we gave it a formal name, the community faculty track. We did faculty development. We helped them develop their dossiers. We worked with them to develop a curricula for teaching a class or two. And then we created and they were submitted to promotions committee. And everybody also they were co-authors on as many as 5 to maybe 50 publications at the time. And so we got it up and going. And we were able to get an endowment grant through the NIH, and we're using funding of that to give them some support for their role at the university. And we felt that was a good way to bring in to the university individuals who are teaching or co-teaching who really understood the social determinants of health. It's one thing to have a faculty talk about domestic violence. It's another thing if they're talking in partnership with the person who's the CEO of a domestic violence shelter, right? It's a completely different frame shift there. So we did that. At graduation, I had them dress up at graduation and come to graduation. And so it continues to go on. I would have liked to have seen it grow more. So I was at Charles Drew, now I'm at UCLA. Many of those individuals work with us at UCLA as well. They've been teaching in the School of Public Health and for many of our fellows, research fellows, for at least the last 20 years now. They've been co-teaching a lot of classes. So it's something we're proud of, but we'd like to see that expand. So I'll sort of summarize with some guiding principles, which I took from Stanford website, because I thought it really captured them well. Right, build mutual respect, trust, and authenticity, sharing the benefits of resources, lowering the barrier for partners to access Stanford resources. That's what the community faculty track did. They had IDs, they could access the resources very easily. Commit to working together long-term, very difficult, but critical, right? Prioritize communities that are disproportionately impacted. Balancing power, sharing resources, identifying strengths and assets in the community, not just deficits, and addressing the structural inequities. 2 things that are really important I thought about, let me jot it down. One is succession planning. Much of this work, a lot of times we're working with community leaders and the leading organizations, and if there's not succession planning, there's an opportunity to fall apart. And it happens on the academic side as well, but a lot of times we sort of see individuals who are bigger than life, and if they go away, there can be a big drop off. The other is my recommendation is to work with community advocates, not community activists, right? Advocates are individuals, at least the way I would frame those is advocates are individuals who are looking to improve the health of the community as a whole. Activists have a particular aspect that they're interested in and focused on. And that can be fine to do that. But usually for community partnered work, we're looking for someone who has a broader view of moving forward an initiative. Now, there may be projects for which working with activists is the best way to go. But in general, I think about we want advocates. And then again, also consider the MOU. So what about who's thinking about what the daughter said, right? So we have what the daughter said. So the daughter called some friends of hers and her mom's, us at UCLA, and said, this is what's going on. And so we eventually got her transferred over to UCLA. And instead of going to a nursing facility with a DNR, she was discharged a week later and went on to do her work. 4 months later, this is me walking her in to conference room at UCLA, where she received the UCLA medal, the highest honor that UCLA confers, right? And so it's important, we're thinking about treating our patients, treating our community as if they're part of our family. But most importantly with this, while that was gratifying that it worked out well for her, what it always says to me is, what about the other people that don't have those relationships and don't have those connections? How many people are being placed on DNRs and going to nursing facilities and getting suboptimal care because they don't have those connections? So one thing we want to do through community partnered, community engaged research is to increase the health literacy, the health connections of our community, and put them in a position to be able to do like Loretta was able to do. So I want to acknowledge a variety of my community partners who I've worked with over the years. These are many of from our CTSI, our Community Engagement Research Program, bunch of other shout outs. And then thanks to Stanford for launching the community partnership and doing some of the great work you're doing here. And I'll end with this quote from the late UCLA basketball coach, John Wooden. It says, "You can't live a perfect day without doing something for someone who will never be able to repay you. You can't live a perfect day without doing something for someone who will never be able to repay you." So I'm wishing everybody here many perfect days ahead. Thank you for indulging me, and happy to have questions and answers. I hope to entertain them and maybe even answer some.
Thank you, Dr. Norris, for the great talk and merging Stanford mission, community engagement mission year speech. Also, thank you for sharing the early pioneers in this field, like Dr. Geiger and I think Moses Haynes. My first question, I will take permission of from the audience virtually, and here that I'm going to ask the first question. So early, through your talk, you visited the economical impact, as well as for community engagement. It needs funding and resources, and the resources go to the academic institutions. Given the new federal government changes in grants, how do you see this going to impact, or will it impact the community engagement initiatives and efforts?
Yeah. Great question. Great question. Recently, the NIH had started some programs where funding went to the community partner, right? Direct funding from NIH to community partner. But those community partners have to be fairly advanced to be able to handle the grants management. We struggle at our universities doing that. But now the bigger question has become, as you bring up now, this sense of, is there opportunities for work in health equity and health disparities to continue? And we see this, and the concern is there's a big, at the federal level, stopping all DEI offices, right? So DEI offices are offices in sort of human resource spaces, things of that nature. And that's a conversation we have later around whether that should or should not happen or change, et cetera. What we do as health equity, health disparities researchers is we work to advance the health of communities or populations with the greatest burden of disease or greatest risk of disease. That's what we do. And we do that to try to improve the health of our communities and our country, and to improve the economics of our country. Don't let anybody tell you you're doing DEI stuff. DEI is a space that's a whole nother discipline, right? So we do the work that we do. That's another discipline. That's another conversation. And so what I've been trying to tell our faculty is stay strong, be clear about what you do and why you do it. Now, there are some words that we use that happen to have the words diversity, equity, inclusion. So there's an overlap, and you do want to probably minimize your grant being pulled out and scoured through, et cetera, et cetera. But words have different meanings in different spaces, right? In Wall Street, equity is a big word all over. Private equity, 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 equity everywhere in Wall Street. There's not a person in Wall Street who's not trying to diversify their portfolio, right? So these words have different meanings in different spaces, and they mean different things in the space where health equity and health disparities research is going than they mean usually in offices that are working to address issues around hiring, et cetera, et cetera. So that's a completely different conversation. We need to focus on what we do and how we do it and why we do it, and make sure that there's clarity around the importance of the work we do to make our country a better country. Now, that being said, there are people doing some work, some people doing work in health equity, health disparities in the areas of gender health and undocumented persons. That's going to be a challenge. And so people may have to, depending on the type of work you're doing, how it's framed, you're going to be looking at private funding to help continue that work, or people may have to transition and make a pivot to do something related to keep their career going and maybe come back later, or maybe they'll find that they like whatever else they're doing now. So those are sort of my thoughts.
It's an academic, yeah. It's kind of an academic question, but can you comment on the discussion about whether it's social determinants, social drivers, social needs, and whether that's setting us back or whether it's opening new ideas?
Great question, right? So social determinants and structural drivers, I think, are kind of similar. The better term is structural drivers, I think, because social determinants is much more embedded in the vernacular, but it has a sense of it can't be changed because the word determinant is used, whereas driver has a sense that it can be changed. And so a lot of times I write structural drivers / social determinants of health, SDOH. It happens to work out well. Social needs tend to be more individual oriented rather than community structurally oriented. And CMS has a list of social needs that they want us, particularly for Medicare, and for organizations that are getting Medicare funding or Medicare Advantage companies, to make sure that they're addressing social needs and that you have done a social needs checklist on your patient. So those are both important. Those are really important questions, and that's probably about what I know about it. Thank you.
We have a couple of questions online, Dr. Norris.
Cool.
First of all, Dr. Golden, your mentee, graduate 95, he said, great lecture and good to see you there. There's a new Golden at UCLA is what he said. And then Dr. Patel said, I love the building of research capacity and community and the training and transition to community faculty. How is this supported, and what would we need here at Stanford to mimic this? In other words, like funding, support from the top, champions.
Right. So it was support at the time. So it was at the time, it was initially supported by funding through center grants that had community engagement cores. And so we used money to, to support people who are doing activity there, but that's kind of related. Some of it would be related to core, sort of general core activity for promoting community engagement. Some might be specific for a project. That doesn't give the sort of the requisite support that one needs to keep someone engaged long-term. So we thought about it, how do you make sure somebody has maybe 10, 15% support to continue a relationship with the university that might be, and might engage in A, B, or C. So what we were able to do at the time was there was a NIH endowment award for institutions with low levels of NIH funding. And so we had gotten an endowment award. So I would say endowment is a way, right? And then, and not, you're not paying people full-time, but you're paying people maybe 10%, 15% to be on. I think we decided on $75 an hour, but it may vary depending on what people's backgrounds are and what they do. And then they would have a scope of work that they do. It could be teaching, it could be working on partnerships, it could be helping faculty connect to the communities and partners that they need to do the work they're doing, because they may have specific work and activities that they're doing and specific studies that they're trying to get up and going. And so sometimes it can be, recruitment for a study, right? So that every project doesn't have to be a fully partnered project where community is involved from the beginning to the end. But it's important that project may differ now, because there's going to be a better understanding of why people are being recruited into it, there could be more and better strategies for report back to the local community and not people waiting till it comes out in JAMA, because like every community member is waiting for the next JAMA article to come out. So those are some of the strategies, but I think endowment is a good way. It's not really a lot of money per se. You know, if you have, you know, $100,000 or $50,000, you know, depending on the number of faculty you have, and you know, you can have a small cohort of people, and then the rest of it can be funded on other grants and things of that nature.
Dr. Norris, Jonathan Shaw, Associate Chair of Community Partnership Program. First, I just have to say a heartfelt thank you for the shout out for our program, and to give a shout out to Alex Blacker. I'm glad we updated our website with the slide you shared. But you know, we are nascent. We're a couple of years old in launching this, so it's really humbling to see the work you've done. And my question is along the lines of what it takes. I appreciate the slide about saying there is a science here. This is real science. In terms of getting this outside of, like, this is public health and primary care work, how did you engage, and what lessons do you have for engaging your specialist colleagues and saying, you know, this is not just the realm of primary care or public health?
Yeah, great question. So when I got pulled in by my community partner at the time, CBPR work was being done with community organizations and schools of public health, schools of nursing, social work, sociology, anthropology. Medicine didn't do that. Medicine couldn't care less. All medicine wanted was patients recruited for our study, right? And so over time, we've seen more and more transition into medicine saying, oh yeah, this is really important. This can be really helpful. And you know, so we see it now in our specialty organizations in nephrology, where we have community partners on, you know, all the boards, all the organizations. I was on NIDDK Council, winding up, we have NIDDK Council had community members on there, CEOs of American Association of Kidney Patients, to make sure the community voice is there, right? And so we've seen a big transformation. So I think there's enough going on now that if nothing else, we can tell our colleagues, if you don't do it, you're going to be left behind. And those that are doing it, when it comes to study section, when it comes to presenting to philanthropy, et cetera, they're going to be, when it comes to meeting with legislators, they're going to be in a more powerful position than you. And you don't want that to happen.
Thank you, Dr. Norris, and all attendants, and share me in giving 2 hands to Dr. Norris.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.